Good morning, or good afternoon, good evening, wherever you might be. It's my pleasure to welcome you to this ITMIG webinar. This marks actually a special occasion for us because it actually falls on the 11th birthday of ITMIG. The star of this webinar is Dr. Arun Rajan, who is a senior clinician and researcher at the National Institutes of Health. Arun is also really a leader in development of novel systemic therapies and thymic malignancies. He is really at the forefront of research in this area, both things that he is doing himself as well as what others are doing. So he is really an excellent person to give us an update on where we are. It's a pleasure to have Arun.
Many thanks for your time and interest in this webinar. I'm very grateful to ITMIG for the opportunity to share my thoughts on oncological treatments for advanced thymic epithelial tumors. So we thought we'll start by defining a few terms that are used in the management of these cancers, and then talk broadly about treatment strategies from a medical oncology perspective. I have no disclosures relevant to this talk. So in terms of definitions, this is not by any means an exhaustive list, but it contains the important terms that are commonly used in clinic. These can be tumor-related terms or treatment-related terms. There are certain measures of clinical activity that we frequently use, and some terms that are specific to clinical trials, which I will talk about briefly. In terms of tumor-related terms, the most obvious is the term thymic epithelial tumors, which is a collective term for cancers that arise from the thymus gland. I have seen reports where terms such as varied as thymic cancer or thymic tumor or thymic carcinoma are used as a collective term, but one should use the term thymic epithelial tumors to define cancers that arise from the thymus gland, which include thymomas, thymic carcinomas, and thymic neuroendocrine neoplasms. Now, staging is the extent of spread of disease. We use the TNM system for staging thymic epithelial tumors, and histology is the tissue characterization of the features that you observe under a microscope, and we use the WHO grouping for this purpose. As these concepts have been explored in previous webinars, I shall not go into details at this time. Now, in terms of treatment-related terms, you could talk about the type of treatment, which includes systemic therapy, a term that is used to define treatment that reaches all over the body, affects all the cells, and classically was used to define chemotherapy, but nowadays targeted therapy and immunotherapy can also be defined as systemic therapies. In terms of local therapies, in contrast, these are directed at a specific organ or anatomical region of the body. So treatments such as surgery, radiation therapy, or ablative techniques such as cryotherapy and thermal ablation come under this category. You can also define treatment in terms of intent, curative intent versus palliative intent. Definitive therapy that is used with an aim for cure is treatment delivered with curative intent, such as surgery, whereas treatment that is given for a chronic condition which is designed to improve survival and quality of life is deemed a palliative treatment. Now, in the treatment of advanced unresectable thymic epithelial tumors, one uses chemotherapy or one of the systemic therapies mentioned above. Since this treatment is delivered with an aim to keep the disease under control for long periods of time, improve survival and quality of life, these are by definition palliative treatments given by the palliative intent. And I think it's very important to understand that the term palliative, that the word palliative, does not necessarily suggest a condition, a situation where one is not delivering tumor-directed therapy. These systemic therapies are all delivered with palliative intent, and I think that is something important to know and take away any misconceptions surrounding the word palliative. Now, we can also define treatment in terms of its relation in time to the primary treatment modality, which is often surgery. So you have induction therapy or neoadjuvant therapy, which is given before surgery, and you have adjuvant therapy, which is given in the postoperative setting, which could be something like radiation. So that is defined as adjuvant therapy. There's also the term maintenance therapy, which is given to keep the cancer from coming back after a primary treatment modality has been used. This does not have as much of a well-defined role in the treatment of thymic epithelial tumors, but it is a term to be aware of nonetheless. Now, in terms of measures of clinical activity, this is again very important. An objective response is defined as a measurable response. So how do you quantify this? In clinical trials, it is defined as a 30% decrease in the size of what are considered target lesions. If the decrease in size is less than 30% and the tumor has not grown by more than 20%, we call that stable disease. So that is the definition whereby the cancer is neither increasing nor decreasing in extent or severity. Progressive disease, on the other hand, indicates cancer that continues to grow despite treatment, or it may even spread. And that is defined as a greater than 20% increase compared to baseline or the appearance of new lesions. So these specific quantification parameters are used in clinical trials, but in general, when you talk about a drug X having a response rate of, let's say, 25%, that is what is meant in terms of an objective response. In the age of immunotherapy, there is also the concept of pseudoprogression, which refers to an increase in tumor size or appearance of new lesions, followed by tumor regression, which may ultimately convert into a response. So hence the term pseudoprogression. And it's beyond the scope of this talk to discuss this in greater detail, but perhaps we can do so in a separate forum. Now, I just want to go into this definition of an objective response a bit more in detail. This may be a bit complicated, but I think it's very nuanced, and it's very important to understand this to figure out what one really means when you say a drug has a certain response rate. So here is a graph which shows the decrease in tumor size from baseline, and in some cases an increase. This is actually from our phase 2 clinical trial of sunitinib that we completed a few years ago. The response rate defined by the trial, and which is often quoted when sunitinib is used, is about 26%. That 26% refers to the 6 individuals with thymic carcinoma in this trial who had a decrease in the tumor size by 30% or more. However, as you will note, there were individuals who had nearly a 30% decrease, and the difference here might have been a millimeter or two in terms of measuring and quantifying response. And there were several others who had a significant decrease in tumor size. They felt better, their quality of life was better, but it did not meet the criterion for an objective response. So an objective response gives you an idea about the people who will benefit. The higher the number, the better. But it should be recognized that there is a substantial number of individuals who will derive benefit from a particular drug, but that may not be reflected in the particular number that one uses to quantify the objective response. So moving on, there are other terms that are used to define clinical activity, including duration of response. That's the length of time from detection of response to disease progression. And then survival parameters, including progression-free survival, which is the length of time during or after a particular treatment that a disease does not get worse. Our aim when we do trials and develop new drugs is to essentially improve upon progression-free survival compared to standard therapies. And the same is the case, obviously, with overall survival, which is the length of time from the date of diagnosis or the start of treatment that an individual is alive. And again, there are a number of nuances in this. It goes into clinical trial design, etc. It's beyond the scope of this talk, but ultimately we want to develop newer treatments which improve progression-free survival and overall survival and may or may not be associated with very high response rates. Now, in terms of clinical trials, there are a few terms. I don't want to spend too much time here because I know there's a webinar coming up in June related to clinical trials, so we could talk a bit more then. But just know that generally, when we talk about phases of clinical trials, you have phase 1, which these are trials used to find a safe dose and determine the best route of administration of a certain drug. Phase 2 studies, which are somewhat larger, and they're used to determine clinical activity, so determine the effects of a treatment on a cancer and assess how it will affect the body and the cancer. And then phase 3 studies, which are large randomized studies to compare a new treatment with the currently existing standard. Now, thymic cancers, given their rarity, are not easily evaluable in a phase 3 clinical trial because of the numbers involved. So all the drugs that are out there which are used for management of thymic epithelial tumors are used based on data coming out of phase 2 clinical trials, which we conduct. Also, one point to note is that phase 1 studies may not necessarily be evaluating a drug which is completely unknown. It may not be evaluating a drug where you don't know the therapeutic dose, because if you combine, for example, 2 drugs with known activity for the first time, you have to determine safety, and you do it in a phase 1 clinical trial. So when you're offered a participation in a phase 1 study, it is important to recognize that this may not necessarily mean that you are going to receive a drug which has not shown evidence of clinical activity. Very important to recognize that. And then there's the term pilot study, which is an initial study examining a new method or treatment. And again, just like phase 1 studies, it does not necessarily mean the intervention is a complete unknown quantity, because you may be, for example, looking for biomarkers of response, lab tests for response or toxicity, but the treatment itself may be effective. So there are nuances which we can talk about in detail at another point in time. And an adverse event is an unfavorable medical occurrence, commonly called side effects. These can be related to the treatment or not, but that's a term we commonly use when we perform clinical trials. Now, in terms of strategies of management, I'll spend the next 10 minutes or so giving you a broad overview. You all know that in terms of the stage of disease, you can classify thymic epithelial tumors into early stage, locally advanced, or advanced cancers. Our aim today is to talk about management of advanced stage thymic epithelial tumors, and that's what we'll do. You know that the backbone of treatment is systemic therapy in these cases, and for the most part, it's chemotherapy, although we have developed newer drugs, including immunotherapy. And then there may also be a role for surgery or other local therapies, and it's very important to keep that in mind. So frontline treatment for newly diagnosed disease consists of platinum-based chemotherapy, as we call it. The common regimens are a combination of cisplatin, doxorubicin, and cyclophosphamide, known as the PAC regimen. This is administered intravenously over 3 weeks, up to 6 times. It could be done over a single day or in an infusional form over a few days. The side effects of chemotherapy include low blood counts, hair loss, nausea, vomiting, diarrhea, fatigue, and loss of appetite. Many of these side effects can actually be very well controlled with the newer generation of supportive drugs, but there are other side effects that can affect particular organs based on the properties of certain drugs. So for example, for cisplatin, it could affect kidney function, peripheral nerves, and hearing, and one needs to be cognizant of this. And in the case of doxorubicin, at high doses, high cumulative doses, it can affect heart function, and we are very, very cognizant of this and manage patients accordingly. Another regimen is carboplatin with paclitaxel. These two are intravenous drugs administered over every 3 weeks, up to 6 times, done in an outpatient setting over a few hours. In addition to the side effects of chemotherapy, paclitaxel can also cause muscle and joint aches, flu-like symptoms. It can affect peripheral nerves, and it can also cause allergic reactions, because of which we give you pre-medications to decrease the risk. Cisplatinum with etoposide is another regimen. In this case, the treatment is given over 3 to 5 days, cisplatin on day 1 and etoposide over 3 to 5 days every day. And the treatment is repeated once every 3 weeks for up to 6 times. The side effects are, again, those you see with cisplatinum in particular, and also chemotherapy in general. Now, these treatments can be delivered with palliative intent. And again, remember, the word means tumor-directed therapy in this circumstance, which is used to improve quality of life and decrease tumor burden, improve survival. Now, sometimes you can start with that intention, but you find, as in this case, a patient having a large burden of tumor in the right chest to begin with, has a very good response and minimal disease after completion of chemotherapy, and then you decide to go ahead with surgery. So what started off as treatment with palliative intent turned out to be essentially curative intent induction therapy, which was given to this individual. Now, for second-line treatment and beyond, there are various choices. They include chemotherapy, targeted therapies, and now immunotherapy. the overlying goal is to diminish symptoms and improve survival. These are some of the drugs which are commonly used for chemotherapeutic drugs which are used for treatment of thymic epithelial tumors. Pemetrexed is really active against thymomas, not so much against thymic carcinomas, whereas the other three drugs are active against both histologies. I have enumerated some of the specific side effects that can be seen with these drugs, but generally single agent chemotherapy is well tolerated and patients do fine in many instances. Now, targeted therapies are drugs which are designed to target a specific biological pathway, although the mechanism of action may not necessarily be what you would expect. So in other words, for example, some drugs have immunomodulatory properties, which may be the reason why these drugs work. Examples here are sunitinib, everolimus, lenvatinib, and the hormonal treatment octreotide. Octreotide is given as an injection, subcutaneous or intramuscular injection, but the other drugs are given orally in tablet form. And it should be borne in mind that although these are given as tablets, and they may seem very straightforward, they can have a number of side effects as listed here. And sometimes they are more difficult to tolerate than chemotherapy. So please do bear that in mind. Close monitoring is required when you're on these drugs. Sunitinib and lenvatinib are effective against thymic carcinoma. Octreotide is effective against thymomas that express a certain receptor called somatostatin, which can be detected by special scans. And everolimus is effective against both histologies. And then there is immunotherapy, which is largely represented by immune checkpoint inhibitors, such as pembrolizumab or Keytruda. These activate the immune system against a tumor, but they can also cause inflammation of organs, other organs due to immune stimulation and cause very severe side effects. This is especially true in the setting of thymic epithelial tumors due to the underlying biology of the immune system. And I think everyone is in agreement that these drugs should not be used to treat thymomas outside of a clinical trial. And personally, I feel even for thymic carcinomas, when given a choice, these should be used in the setting of a clinical trial, because they can cause severe side effects. And if they are used in the community, as in reality they are for thymic carcinoma, the treatment should be monitored very, very closely. Now, is there a role for local therapy for advanced thymic epithelial tumors? So this question comes in this sort of scenario where you treat someone with chemotherapy, frontline chemotherapy, they do well, and at some point, unfortunately, the disease comes back. Does it automatically mean we go to second-line therapy and then third-line chemotherapy and maybe immunotherapy? Or is there a way to mix and match treatments in order to maximize benefit? So an illustration of that phenomenon is here on this slide, where after that frontline chemotherapy, you could theoretically use systemic therapies as part of a clinical trial, or second and third line chemotherapy. You could use local therapies such as surgery or ablation, or perhaps no treatment, just monitor the disease, because sometimes things can just stay stable despite the lack of active treatment. So can this really happen, or is this just a theoretical construct? So let me give you an example of a patient of mine who was diagnosed with a stage 4A type B1 thymoma, which was deemed unresectable. This was more than 10 years ago. He received standard frontline chemotherapy for disease which was present in his right chest, and this is just an example of that. After 5 months, he completed chemotherapy, had a good response with significant shrinkage, and then we found that his disease was operable. So he underwent surgery, he got post-operative radiation, did well with all of that. But unfortunately, 1 year later, he had recurrence of disease in the right chest, as indicated by these areas of PET positivity. So once this happened, we decided it was a minimal amount of disease. He could maybe go back and get surgery, which was done. But 6 months later, unfortunately, once again, you began to see disease in the abdominal, abutting the abdominal wall on the right side. So at this time, we thought perhaps surgery is not such a good option. It's a major procedure. We should go on to something systemic, also because the disease is no longer present exclusively in the chest. So we offered a clinical trial, and he actually derived benefit from this. His symptoms improved. He stayed on it for more than 1 year. The disease did not shrink substantially. So again, this was stable disease, but his symptoms improved and he felt better. But after about 16 months, some of the side effects of treatment began to add up and his quality of life was being affected. So we decided to stop. But at this time, the question was, should we move on to another line of chemotherapy, offer surgery to resect this lesion, or do something else? What we actually decided to do was just observation. So we said, let's just keep an eye on this. The tumor is progressing slowly over time. Maybe we can just watch it for a while. And we were able to do so for more than 1 year. For 15 months, we did scans, we kept an eye on things. But 15 months later, he began to have some abdominal chest wall pain, and we noticed that he had some pleural lesions develop in the chest. So at this time, we started pemetrexed, second-line chemotherapy, and he did quite well with it once we controlled the dose, his side effects, and adjusted the dose. He got this for more than 3 years, at which point he developed one lesion, which may not be very appreciable here, but it was along one of the ribs, and it was causing chest wall pain. So here, one would not be at fault if you moved on to the next line of chemotherapy, but we decided to try something different because there was just one site of active disease which was not under control. So we offered what is known as local ablation using cryosurgery, where this particular lesion was treated with success and then put the patient back on chemotherapy, in other words, pemetrexed, which he continues to receive to this day after more than 3.5 years of treatment. So what you see here is 11 years have elapsed since diagnosis. There have been periods of recurrence of disease. And at every time point where there was a chance to, there was a need to switch to something different, we used a combination of techniques rather than relying just on systemic therapy, and in effect used one additional line of chemotherapy, and we have several others left in reserve to use in the future if needed. I have to stress that this may not be something that can be used for all patients. It depends on the type of tumor, its biology. It's a very aggressive cancer which is growing quickly. You cannot do this sort of thing. It depends on the surgical and interventional radiology expertise that is available, to offer these sort of treatments. It depends on the location of the tumor. If it is not approachable for local therapies, then you have to move to something different systemically. So I don't want to give the impression that this can be used in everyone, but certainly in my mind, it is a question to ask and constantly evaluate in order to maximize benefit. So in conclusion, I would say that advanced thymic epithelial tumors are treated with systemic therapy largely. Chemotherapy is used to treat newly diagnosed disease. Both targeted therapy and immunotherapy have not found a role there as yet. Several options are available for treatment of recurrence, but as I tell my patients, these options are ultimately finite. So you've got to be very, very careful in using your judgment as you use these different trials or these treatments. Because the choices for targeted therapy are limited due to underlying tumor biology, and immunotherapy, although it has a lot of promise, should be used with caution, and it may not be a good idea to use it in patients who have underlying autoimmunity. So there are limitations with immunotherapy. And as I said before, all of us, I think, would advocate for use of immunotherapy only in the context of a clinical trial for thymomas. And personally, I feel that way for thymic carcinomas as well when given a choice. And as I showed you, local therapies can be considered in very carefully selected circumstances after discussion in a multidisciplinary setting. And that's where comes the importance of a forum like a tumor board, where experts from different specialties are there together and determine the best course of action. So with that, I'd like to conclude. I hope this has been helpful. Thank you for your time and attention, and I'm happy to take any questions.
So Arun, thank you very much. Let me perhaps start off with just a question, since we're talking about a decade or a little bit more of ITMIG. How do you view things if you think back 10 years ago, 20 years ago, and now, and then looking forward 10 years? How do you see the progress over time in terms of systemic therapies for thymic malignancies? How much have we picked up speed? Where do you think we're going in the next 10 years? Oh, I think you're muted.
I'm sorry. Thank you again for that question and for the kind introduction. Um, I certainly think there have been rapid advances in the last 10 years, during the course of ITMIC's existence, in large part facilitated by, the collaborations that are fostered by the group. I think a lot of this is relevant and has had an impact in terms of targeted therapies, genomics, understanding the biology, the genomic biology of the disease, and with an aim to identify new drug targets as a first step towards developing new treatments. And certainly immunotherapy, which really came into the fore for treatment of cancer in general during this time, during the last decade, with immune checkpoint inhibitors. And obviously that's had a role for the treatment of thymic malignancies as well. I think in terms of chemotherapy, the options that we had about 10 years ago are still the options that we have now. I think the drugs, there's probably a finite role in terms of what chemotherapy can offer, and we continue to use the same drugs today. Moving forward, I would say, as next generation sequencing and genomic technologies become more widely used, and there are large efforts like the Cancer Genome Atlas, the TCGA project, which obviously has studied thymomas as well. There is ample opportunity to discover newer targets and develop drugs, targeted therapies, which hopefully are more effective than what we have available to us at present. And certainly there's a whole lot of things that can be done, in the field of immunotherapy. I think we have barely begun to scratch the surface, with immune checkpoint inhibitors for diseases like lung cancer, for example. You could use cancer vaccines, you could use, other immunotherapeutic modalities. The key, as you know, for thymic tumors is the ability to understand why the immune system overreacts, why you have immune related toxicity, which can be potentially fatal, and how you overcome that. So I know a lot of our institutions, including ours, have spent an enormous amount of time trying to conduct these immune correlative studies and identify biomarkers of response and toxicity, especially toxicity. So I think that would be the focus of a lot of active research going forward.
Okay. So a couple of questions here from the chat. Marina wants to know about sunitinib in people that have no c-KIT mutation.
Thank you, Marina. That's a very important question related to the role of a genomic biomarker, not only for SUTENT, but for other targeted drugs as well. So I think the bottom line is, if a KIT mutation is present, there are different types of KIT mutation, of course, but if they are present, it is likely that a drug such as sunitinib would work, assuming it's a sensitizing mutation. But I think the key thing to understand is the opposite is not true. In other words, if there is no KIT mutation, or there is no mutation among the targets of sunitinib, it does not mean that the drug will be inactive. And we have shown that in our study. As I pointed out, we had 6 patients with a partial response and a few others who nearly met that criterion. And not one of them, not a single patient, had any mutation in the known targets of sunitinib. We, in fact, did additional studies and found that there were immunological changes that could explain activity. Sunitinib is known to have immunomodulatory properties. That's not new. So I think, in a sense, what I would say is, a KIT mutation, if it's present, might indicate the ability to respond, but the lack of a KIT mutation should not prevent one from using sunitinib or considering it as an option.
Okay, another question here from Sabet, who has thymic carcinoma, stage 4B, and considered getting some chemotherapy and decided to just do observation, no treatment. And her reasons were that she actually had some symptoms for many years before she was diagnosed, and that she felt that there was really no standard for chemotherapy treatment, and so said, well, maybe I'll just wait and see. And she wants to know, is this a reasonable approach? I guess this has been going on now for 3 years, and I'm happy that she's here asking us this question.
Yeah, thank you. I think that's also a very important point. So I would say from a systemic therapy standpoint, from a medical oncology standpoint, obviously for 4B disease, systemic therapy is the standard, and platinum-based chemotherapy is considered the frontline regimen. I think about that, there's universal consensus. And then I talked about, various options that could be used subsequently. So I think overall, there seems to be some degree of consensus, especially for frontline treatment. But having said that, I think you bring up a very important point about what might be the right time to start treatment. Now, in general, thymic carcinomas, as we all know, can tend to grow maybe a bit faster and more prolifically than thymomas. But have we seen instances where thymic carcinomas, for whatever reason, have been rather slow growing, rather indolent? The answer is yes. We've had patients with thymic carcinoma. We wonder sometimes if the histology might have been actually different, and it's a reflection of just a limited amount of sampling with a biopsy. But for whatever reason, growth has been relatively limited. So in that circumstance, can one just keep an eye on things and observe things? I think the answer is yes, but it's a very, one has to be very cautious with that and monitor things closely so there isn't tumor spread, in the absence of active treatment. So I would say that merits a discussion with your medical oncologist. It really depends on the trajectory of the disease in the past. But when the time comes for treatment, I think there's fairly good consensus actually that one should use platinum-based chemotherapy as the frontline strategy.
Okay, here's another question that might be a little quicker from Natalie. Her husband has been told that he can't have immunotherapy because he has myasthenia. Is that true?
I'm afraid that is true. That is true. I think that's the short answer because the risk of inducing not just worsening of myasthenia, but potentially very severe muscle inflammation, including heart muscle inflammation, is very high. So I think that is true. We would say this would be a contraindication to the use of immunotherapy.
So if Joshua is still on, I'm going to turn this one to Josh. The question is there any benefit to debulking surgery in patients with a large tumor burden?
I'm here.
Good.
Is there any debulking therapy? That's controversial and very patient specific and on age. I would say generally no, if debulking means leaving gross disease, like big chunks of it. If you think you're technically doing a good operation as best you can, and there's going to be some residual disease of minor, but technically it's not a complete resection, so you could define it as debulking, it'd be yes. I guess the short answer is few and far between should go with the intent of debulking, but it's not an absolute. I don't know. What do you think, Frank?
Yeah, I would agree with that. I think that generally, if you're leaving gross disease behind, it's probably not worthwhile. But I think that sometimes with microscopic residual, I think in combination with radiation, there are situations where I think that there might be some benefit. So another question here from someone with a type A that is a metastatic type A and has lung nodules, and wondering what systemic treatment options are available for this sort of rare situation with type A that we don't encounter quite as often.
Yeah, so I would say the indication for the use of multi-agent platinum-based chemotherapy upfront is actually independent of the underlying histology. So if one has untreated metastatic type A, thymoma, which presumably is not surgically, resectable, then the recommendation would be to use a platinum-based combination for treatment.
Okay. Let's see. So another question here. So this is a phase 2 trial in the US involving KN-046. And, is there any perspective on when this drug will be approved in Europe? And what is the experience with thymic carcinoma?
So maybe I'll defer to Nicholas about the situation in Europe. But as far as I'm aware, this is a combination, sort of a immunotherapy combination, a PD-L1 antibody with, if I'm not mistaken, a CTLA-4 antibody. They're sort of combined. What is the perspective in relation to thymic carcinoma? I'm not aware of any trials that have evaluated it specifically for thymic epithelial tumors. But I think the general rules will apply. It is immunotherapy. It involves immune checkpoint blockade. In general, from other cancer types where these sort of drugs have been used, we see many a time the side effects that you see with CTLA-4 antagonists are in fact more severe and could be more frequent than they are with PD-L1 antibodies. So a lot of caution is merited. And I think this sort of thing should be explored in a clinical trial, really, to be quite honest. Even if it's available for off-label use. And the same rules apply in terms of a contraindication if there is, if one has an autoimmune disease or a predilection towards autoimmunity.
In Europe, this drug is not approved. It's still under investigation through clinical trials. I have to mention that regarding the combination of anti-PD-1 plus anti-CTLA-4 immunotherapy, we have an ongoing trial, which is NIVO-TEAM. It's an EORTC ETOP trial, now recruiting patients with this combination. So maybe if we show a benefit from this combination, this combined antibody would be valuable and could be specifically assessed in thymic tumors. Again, without any autoimmune disorders and probably only type B3 thymomas and thymic carcinomas.
Oh, a question from Brooke about, is there a role to revisit treatment with PAC chemotherapy?
Thank you, Brooke. So I think in principle, could you repeat a platinum-based combination? The answer is yes, provided a certain amount of time has elapsed after the initial use of these drugs. Generally, there's no fixed guideline, but generally the rule of thumb is 12 months or more. So if one has to consider using it after several years after initial use, if the disease is showing signs of activity, you could potentially consider repeating the platinum-based combination. However, in terms of PAC specifically, there's one very important thing to recognize, which is the A in that PAC, which is adriamycin or doxorubicin, is potentially cardiotoxic at high doses. So I think the limiting factor in repeating PAC would be really the cumulative dose of adriamycin. There's actually a lifetime dose that we calculate, and you should not go over that dose, because then the curve of the risk of cardiac damage increases very substantially, especially if you have also got chest radiation. So I think that would be the limiting factor. But could you repeat another platinum-based combination, several years later, such as carboplatin with paclitaxel? The answer is probably yes.
All right. So another question from Sabet. She had a biopsy, although it's a little bit unclear to me, Sabet, if certainly I think that a biopsy has value, I think, to define treatment, to define the diagnosis, to define the extent, and isn't necessarily the same thing as a attempted debulking resection. So then Sabet asks a question about, have you conducted any trials using low-dose chemo with thymic carcinoma?
Personally, I have not. Nicholas, any thoughts on that?
Not really. Don't know not aware of any data with such strategy. Still, we have been using standard chemotherapy for many years, and maybe the development of new compounds will lead to some changes in the way we administer chemotherapy. But for now, I would say even not aware of any trial assessing such strategies.
So, Nicholas, I'm going to ask this question to you, since you've been so involved, with Rhythmic and with European efforts to try to, organize, to disseminate expertise. I guess I would put it that way. Given a rare disease such as thymoma, thymic carcinoma, what do you see is the benefit of that, and how much of a difference does that make when you can have a tumor board of experts discuss a case if you're at a hospital that perhaps doesn't see as many cases of this type of disease?
Well, I think it's the way we should do for any patient with a thymic tumor, because we see in France we have a dedicated national tumor board when we discuss all the patients. So some patients cases are pretty straightforward, small tumor, and you need to do surgery, no problem with that. But in some complex situations, patients with recurrence of the tumor, multiple lines of treatment, maybe we need to have a broader view and discuss also, again, maybe surgery, again, maybe radiation, new drugs, also looking at the radiological images altogether. This is something that is very, very important, because we know that many patients will receive many types and lines of therapies for their disease. So it's very important to have a global view of the treatment sequences, have a decision making that is a multidisciplinary decision making. So to me, this is mandatory. Even if I am quite an expert in treating patients with thymomas and thymic carcinomas, I always discuss my cases at such multidisciplinary tumor board, because it's very important to have the insight from every specialty, and also among different experts in the field.
Yeah, I'll just point out that ITMIG has also organized a international tumor board that is really open for anyone, physicians from different hospitals to discuss a case and, get some input. Well, I think we're out of time here. I certainly appreciate everyone joining. I hope this was useful and informative. You definitely, heard a lot from really one of the world's experts, and Nicholas as well. And I think this is a, great opportunity, I think, to bring some of this more broadly to people that have questions.
I'd like to thank everybody for participating, and these type of collaborations exemplifies what this organization does. Brings people of interest, physicians and non-physicians, with the goal of better understanding and better treating this disease. And as Arun and Nicholas said, even quote us experts, we are expert enough to know that there's a lot we don't know, and we need help from patients and each other to continue to improve. So thank you. Arun, great talk, appreciate it.
Thank you so much again for the opportunity, to Frank, to ITMIG, to all of you. And I completely second what Frank and Josh mentioned. This is a learning experience. We learn every day, even though we deal with these sort of diseases from your experience. So it's really very beneficial. It's two-way communication, and it basically just helps everyone. And that's something we learn at the tumor boards, the ITMIC tumor boards, in a forum like this. So thank you for your time, for your participation, for keeping us, abreast of the questions that come to your mind. It really does help to move the field forward. Thank you very much.
Thank you everyone for participating to this webinar, and thank you again for your support. Take care.
And I also would like to thank all the speakers and the moderator, thank for this webinar. And of course, I would like to thank our audience for your questions. And a short information, we are going to organize the last webinar for patients in the second half of June. The information, more detailed information, will be published soon on our webpage, so please visit our webpage. The last webinar will be dedicated to clinical trials. Some physicians, members of ITMIC, and not only, will present clinical trials for thymic epithelial tumors. So thank you very much for this webinar, and see you next time.